members and to give you this, again, access to meet with Hal every year, but we're also trying to make the experience better for each of you and all the hard work that you're doing, and again, creating a better moment for the next few days for all of our journalists. And so, again, grateful to have Hal here just for a bit with you. We're going to have, you can ask some questions. He's going to go through some updates, but then also, if there's anything that we can't cover today, Albie and I will be following up with you because we still want to continue to keep building throughout the year. So thank you all. Thank you, Hal, for making time.
Oh, no, thank you.
Appreciate it.
Both Christine and Albie have been working really hard to make your experience better, because hopefully if you have any suggestions, let us know. Okay. First of all, thanks. We're really thrilled. I think I wanted to tell you that there's a buzz out there. It seems to be really at probably over 5,000 people sitting in the audience just this morning. That room was set up for a lot. It was pretty packed. The buzz over the last 2 days has just been, the hallways went from kind of quiet, or people drifting around on Saturday. By yesterday afternoon, you saw it yourselves. There was a lot going on. And then today, it's just pretty much what we would call Grand Central Station. So we're really pleased. So we'll stop there, and if you have any questions, I'm happy to jump in and do my best. Sure.
First one, can you just give us an estimate of attendance right now?
Yeah, we're closing in probably around 28,000. There was about 200 from DOD that were told nowhere, nothing to do with HIMSS, but no travel, no etc. But we're looking at around 28,000. That's an increase over last year.
What was the last time?
Last year was...
We're just a little over 26,000.
Yeah, so it's about 2,000 person increase. Where we have seen the biggest increase is on professional attendance. So last year we were roughly around about 10,000 of the individuals were professional attendance, and those mean non-market suppliers, recycler, booths, things of that nature. And this year we're pretty much at 11-ish. So that's a huge increase. There are a number of other events that take place, and I think we've just seen a remarkable and appreciative increase in the interest. The other part behind it, and we'll get you the data on it later, but we also pay really close attention to the titles and the level of the individuals that are visiting us, and we've also seen a big lift there. So the decision-making category and the number of decision makers actually was a real increase this year. We couldn't obviously be more delighted. And it's also a very interesting time. As I tried to intimate on stage, we know that there's a lot of curiosity and churn, and the fact that people have voted with their feet to come here to figure out what's going on, what are the best opportunities I have to improve my delivery, where can I find the greatest innovation that is occurring, where can I meet my colleagues and do the scenario planning, network about what is occurring. That's what we've always striven for, and that's what people have anchored themselves to HIMSS. Yes. But as we listen to comments that come from the administration, I think we can anticipate that there are going to be challenges in programs for the Affordable Care Act, which has a downstream impact on Medicaid. There are going to be challenges to Medicare. I mean, we just know that's going to occur. So when you're sitting in a hospital system and you have those as fundamental steady streams of revenue, when you're doing Medicare Advantage and you're doing other streams of it, you're really planning two things, right? So you're looking at your revenue and you're looking at your operations to meet those needs. So what you can't do is just sit as a strategy person at various times. What you can't do is just sit and wait. So I think we can all safely assume I won't have more money in 26 than I have in 25. And is it going to be a medium reduction? Is it going to be a large reduction? And you've got to get into that scenario plan. So if you're going to have some money to invest this year in digital health, you're going to want to find those tools as soon as possible, right? So that you can go ahead and really jump in. So that was my recommendation.
Al, could you talk in light of that last question and response a bit about Emerge this year? We've obviously brought the startup category so we're closer to the infrastructure support. This is the sort of fluff meeting that was just proposed recently. The startup category.
Yeah.
Together. This is sort of a substance meeting.
I can't comment on that. I didn't attend.
No, I didn't say that to comment on that. But this is a substance meeting. The decision makers are here.
Yes.
You have Emerge. What's your goal?
Yeah, so the redesign of Merge is absolutely to bring applications that are in their second to third phase for getting ready to really enter into the provider. That's the goal. You have, as everyone knows, multiple layers in funding. So you have pure startup, you have second round funding, which usually means they have some level of proof point, and then they bring. We have always been a place where innovation has been brought forward. So when people come to HIMSS, they have always traditionally looked at really three categories. The standard components that sit inside hospital systems, we understand those are the big boxes. They're very important, and they're doing a ton of innovation inside. And you look at the large EMRs, and they're bringing in AI components of it. They're really digging in deep. But we're also dealing with this whole new world of outside in. Care being delivered from the home back. And that is taking a different level because that is new data, new information that needs to be brought in-house, right? One size will never fit all, and there's some great sizes out there, but that's it. So Emerge is specifically designed to bring forward the innovation layers. It's our first year doing it, so if any of you have any great recommendations, we'll tag that on. But it's been very successful. People have really come here because it's not about market suppliers talking to market suppliers. It's about getting in front of actual providers that are decision makers and really bringing it forward. So we're pleased with the first year. We don't have any of the full data yet. And so I'll give you a more learned response after we do our interviews and our talks after. But the initial conversations have been very good. Thank you for asking. Yes.
I have two questions. You partially answered one.
Okay. So I'll partially answer. Yeah,
partially,
put them together.
Yeah. So you can prepare yourself. So just a little background so I can kind of piece the story together.
Sure.
The WHO in Europe and HIMSS came together and created the MOU back in September 2022.
Yes.
And going over like key focus partnerships, like increasing digital competencies, so things like upskilling,
Yes.
healthcare professionals, monitoring implementation, establishing digital strategy. As of March 2025, because as you said, everything's changing every day. So if I have dates wrong, one thing happens one day, the next day it's changed. So forgive me. So as of March of now, the United States.
It's Tuesday, so it
Right.
must be.
So we're in the process of the U.S. is in the process of withdrawing from the WHO as of March 20th for the Executive Order 14155, withdrawal of the United States from the WHO.
Yep.
The UN has confirmed as of January 21st, 2025, the withdrawal will take effect next year, January 2026. Despite these plans, few CDC people are still meeting FDA with the WHO, doing plans over the influenza vaccine. The U.S. is still currently connected with the Pan American HO, like things like us and Haiti. With the withdrawal, the concerns, with these delays, there's concerns about polio making resurgence, which was kind of almost eradicated. And basically, in summary, with having the withdrawal of the WHO coming in January 26th, we're still, as U.S., are connected.
This is the whole article.
I'm getting to the
There's a question here somewhere. I can feel it coming.
And so that's the next statement I'm going to make is my question is, as of today, have some speakers or attendees from the U.S. government have withdrawn their attendance for the communication blackout? You did mention DOD, but I'm thinking like CDC, NIH, different groups. I don't need numbers, but it is some of those groups withdraw. That's my first question.
Yeah. So yes. So there were certain groups in Washington that may traditionally are here and engage, and they've been asked not to travel. It doesn't mean we're not engaging with them in Washington, But, the government is, as you know, they're putting new policies in place and the conversations continue. As far as the WHO is concerned, we are super proud of our relationship, not only with WHO Europe, but also the Pan American components, and there are others that are stepping in. We're going to be doubling down on our efforts with the WHO, especially in the European branch, where we have been working with them in the distribution of digital health and helping strategically with countries that are not necessarily in the European Union, but outside. An example is the MOU we recently signed with Romania, where we're going to come in conjunction with the WHO Europe, give support to their new strategy of digital health and rollout. Why is that important? It's important because many of the countries that we try to work with the WHO on are not the ones that are flush with cash. So if you're in the European Union right now, what you are receiving from the European Commission are loans and funds up to billions of euros that allow you to roll out electronic health records. And basically it's not exactly the same, but it's their version of meaningful use. And we have been absolutely involved in that effort. We've done measurements across Germany twice now, and we'll have a third one coming up through Digital Radar. 1,624 German hospitals. We're deeply involved in the rollouts in Italy, or rollouts in other countries in the EU, either directly with the government, with Portugal, or indirectly with the systems like in the European and in the UK. All those are standard HIMSS activities. But as we look at the countries that are just beginning to put their ecosystem together, this is where HIMSS plays a really vital role. And so working with the WHO, we talk about, we work at ministerial levels to say where is that help needed, and then we go in and work. So while we absolutely understand that there will be changes in the policies by the US government, that's not where our head is. Our head is to help. We stand behind our vision statement in health equity, and we'll continue to do so. And we'll then support wherever we can.
Okay, you pretty much answered my second question.
Cool.
I was going to be asking about this. Was there going to be withdrawal? Was there going to be
No,
more
not at all. I
And
mean,
then-
we're an NGO. Let's be really clear. We are based, yes, currently in the United States, and we're also based in the Netherlands. And so HIMSS is a global entity. We operate on all continents, and we look as an NGO at the policies of every government, and we work with them as best we can to support the citizens and the people that live inside.
And then would it be possible to get a copy or information about the MOU?
There was a press release at the time when that went out. We can get you a copy of that.
That's helpful. Chief Doctor Executive. See you again. We talked a little bit about the uncertainty government funding. I want to ask you something about federal funding for research. The NIH starting to cut the direct funding.
Yeah.
DoD, NSF, VA are agencies that provide a lot of funding for very important causes. How concerned are you about the prospects of less money being available for research?
Yeah, I think we're all concerned. I mean, if you're not concerned, I'd be almost more worried. I think, we have a lot to learn still about where the funding is being cut and what are the impacts going to be. And there's no question that we can all look at almost any kind of funding that occurs and say, yes, no, maybe. Excuse me one second, I made a. Thank you. Sorry about that. I forgot to turn my phone off. Shame on
You're
me.
checking if that.
That's right. Sorry, gotta go. Got a phone call. Thanks for calling, Eric. Okay. So I'm really worried about the funding levels. I think there are no question that we see a lot of great research that comes out of the private sector. And we also know that that's driven by quarterly results. The strength of our system has always been in taking a long-term view. And this is where funding from the federal government or any foundation that is focused on the long-term impacts is critically important. It's not just a government issue. Are there foundations that can step into those models? I hope so, and I know there are. Do we need to understand where? We sure do. So I think we're beginning of a very shaky period in understanding. And that's why I was saying I'm not trying to overreact to what we hear, but I want to understand what we see as well. But am I concerned? Absolutely. How do I measure that level of concern or impact? I don't know yet. I think none of us do, right? So we'll be watching very carefully. Yes, sir.
Absolutely. We're from China Health Television. The quick question we have is, from a global perspective, what differences are observed in terms of development in healthcare informatics, and what are some challenges existing this stage across the globe between different regions?
Yeah. So there's an expression in healthcare that when you've seen one hospital, you've seen one hospital. When you see one region, you've seen one region, and you've seen one country, you've seen one. But there are some fundamental truths that go across everything. One is our aging population. People are living longer, and with that, they bring disease burden, and that expands. We all have neither enough money or enough workforce to be able to fill all of the demands of healthcare. So I think everyone is at a different stage in time as to where they are in building out their facilities and delivering the best care possible. And digital health is a critical element to be able to reach the individual from their home back in the facility. You bet. Other questions? Oh, sorry. I'm going to come back up. You've been fire.
Absolutely, Marina from student. In Japan, IT innovation in some has been slow to progress the innovation. While hospital management and clinical staff, administration staffs recognize its importance to innovation, but concerns for significant operational changes and budget constraints seem to prevent progress. So, in your opinion, what is key?
Which is that all hospitals have to assume the accountability in the use of AI. And what he's in reference to is that whether you're using someone else's tool or something you've developed yourself, in the end, hospital, doctor's office, or whatever, will be held accountable. So there's a liability component built into that, not so much maybe in the Korean market, but certainly here. We haven't had any catastrophes yet. We haven't seen any big lawsuits yet, but something will come. It always does. And that will change the care and the caution. So I think the biggest issue is good governance. It needs to be tied into quality management, quality control, and training. AI is there as a suggestion tool, not to make the decisions. And that's why we call it clinical decision support, because it supports at the clinical basis for that opportunity to bring better decision making forward through the aggregation of tremendous knowledge. You bet. Yes, in the back.
Hi, Ken Harrington, Forest Research. Stepping back to cybersecurity for a second here. I've been around IT for 30 years now, a lot with healthcare. And
I'm sorry.
IT itself, never mind, cybersecurity underneath, has been treated as a line item for a very long time. Sure, it's been increasing as
As a line item.
yeah. And as we've done more digitization, yes, it's kind of come up, but it's still treated as this is only here to enable everything else, and if we have money in the budget, we can get it. As we go more and more digital, things like AI,
Yeah.
more as we saw, like we said, see the use of more and more IoT devices, bots, and all these things, security has to take a precedent that it never did before in healthcare. Is HIMSS sort of driving people towards that? What are you seeing from some of the larger systems that we're talking to globally? Because, like I said, the history has been it interferes with treating patients. I understand that's not one, but You know, we're in this place where hacker ethics have gone out the window. They used to leave healthcare alone because they needed it too.
Okay.
There's huge money to be made targeting health. We see this, we know this.
Okay.
So with all of this, are you directing people to say, can you increase this priority, please, so that we can reduce this threat, as well as what are you hearing back from those big facilities?
Okay. So you got a couple loaded things in that question.
Oh, I know it.
So let's start with the fundamental point about what is HIMSS thinking about and what do we push. We're not about the technology. We're about the utilization of the technology to improve access and quality and fundamental care at the individual and system or governmental level. So we see technology as a tool. We see information as a tool. We separated the IT out into information and technology right when I came on board. It was one of the first things we did. Why? Because it's not about IT, it's about the utilization of those tools. So to be clear, that's where we push. We also recognize the challenges I mentioned earlier on a global basis, and those challenges are partially met, never completely met, through the utilization and the rollout of these tool sets, right? So where do we caution people on top of that? We caution them to think not of, I'll give you my personal line that I was raised in, which is there are no IT investments. There are business investments, and there are quality investments, and there are access investments. But you don't invest in IT just to invest in IT. And I think when you walk the floor of the exhibition, you'll see that, right? We used to call it, where I came from, the so that. You know, what's the so that that's built into utilization and the delivery and through this care components? So the so that for us, you've heard, you know, to realize the full health potential of every human everywhere. So we're fine with that. We've also transformed we've transformed 5 out of 7 of our maturity models now to stop being technology checklists. You can go to other places and get a technology checklist and bang it up on the wall. That's interesting, but the relevancy is its impact on access, its quality, its governance across the line. And that's why we're so deeply involved in the strategic elements of both governments, hospital systems, et cetera, around the globe. So, you know, the cybersecurity and all those other components, we teach that too. We're right there on the caution basis. We have a lot of CIOs. You saw Ellen Assini today up on stage, who's the CIO of a multi-system ecosystem, not only in Italy, but in Poland and France and clinics in Ukraine. And she is a passionate believer in NRAM and the other maturity models that we have. Amazing job as board chair, I might add. So that's where we are. Hope that helps. What did I miss?
So it's, technology is an enabler of all this.
Yep.
But the challenge I've seen over the years, and particularly now, is that the protection of the information,
Yeah.
go back to that, has been not even secondary. We're talking way down.
I don't.
For a long time, it has. It could be not, but it has been put down.
Depends where you are. Depends where you are.
Well, it's a cost.
We're learning.
No doubt. But the attackers see healthcare as a stock market, and it really is. It happens for a while. So I think the priority has to start being brought more to so many healthcare providers, depending on the size, that this has to be brought out of the base, and this has to be made a priority for the staff, because you were saying earlier, it's
but
about processing people, and if my wife's a nurse, she's been doing that for 30 years. So if they don't understand the protection of this information,
That's right.
then it all goes out the window.
That's right. And look, we're redoing the HIPAA rules, as you know, but it goes deeper than that. It gets into cybersecurity, how we aggregate the data. But remember, in the end, data has 3 buckets, 3 pieces. One is ownership, which I will absolutely leave to the lawyers. One is access, and one is utilization. And access and utilization is where we as an industry need to focus. Those are the 2 areas that we get a chance to impact, okay? And I agree with you that is getting more and more heightened in terms of our awareness of the sensitivity and the value. The value not in sense of, but the hackers are there and they'll continue to grow. Yes, sorry, I'll come back.
Seeing a lot of AI hypothetical this round, seeing more adoption than I've seen before. At the same time, from a research perspective, we've seen things recently like canceling grants that are focusing on health equity, including with respect to AI, asking them to change focus of existing grants, all that kind of stuff. So how's that going to impact AI equity, the potential for AI to exacerbate existing health disparities, kind of in the midst of this climate where we're seeing this rapid adoption of these solutions?
Yeah. So if we're taking there's a global perspective and then there's a reaction to the U.S. perspective, but on a global basis, we remain phenomenally dedicated, again, to health equity, and we believe that healthcare is a critical element and responsibility to all citizens and all people. Okay, so the systems that we put together, the advisory services we have, we're right there, and we're going to continue to push that, and we think it's absolutely critical. Regardless of what happens in the next year, okay, inevitably people's voices and needs are going to come back out again, or they will be clear and loud. We haven't seen the impacts yet. We don't know what they are. It's hard to go through full speculation. But look, health equity as opposed to equality, right? We're going for equity, not for equality. And the equity bar is high. Will we ever achieve it perfectly, globally? No, because it always changes. Our job is to strive for it. Okay? And that's really critical. Now, the use of AI in helping it, now you're getting into some really interesting technology territory, which is, are there built-in biases to AI? And the answer is there are. Can you successfully eliminate all biases? You cannot, because everything starts in a root of some place where someone made a decision to start with a file. And people are imperfect. And stop this. But what we are training, and what I'm hearing from the AI ecosystem, is that they're looking really hard to remove those biases. And they're trying to self-teach to remove them. But because they start with stuff that's from humans in the first place, so we've got a lot to learn. I hear your question. It's kind of a repeat of what I said earlier. But, I think that's fair at this point. Let's come back and approach it next year in this room. I think we're back here next year, right?
Yes, right.
So we're back here next year. So more and more. Okay, there we go. Yes.
Fire continues to be a cornerstone of interoperability.
Absolutely.
How would you assess its current state of adoption, and where do you see as the biggest opportunities or challenges for fire?
Yeah, it's a great question. Chuck reached out to me just the other day, and we haven't had a chance to connect again. HIMSS has always been a huge fan of HL7 and the adoption of fire. I think we all get a little frustrated that it hasn't happened faster, and we would like to help them in the rollout of that. So it's really critical. I think we've made great strides in the United States. It's a required transport level for reimbursements, as you know, and globally it's getting adopted too. So when you look at emerging systems and you're looking at their data lakes that they're beginning to get created, and more systems, even if they're brand new, are moving themselves into data lakes as opposed to setting up what we all did traditionally a long time ago, which was to put our servers in a basement and pray it didn't flood. So even if you had a raised floor, right? So I hope that helps. So huge fan of fire. It is being adopted. I wish it was being adopted faster, and HIMSS is going to do what it can to support HL7. And IAG as well. So, we're very excited. Yes.
Let me ask about AI regulation. The administration is taking a lot to approach the recently audits getting AI. Is reducing regulation of AI in healthcare a good thing to speed up innovation, or is it potentially a concerning thing in terms of safety?
It all depends on where you're looking. When you're looking in the operational level, there's not a huge amount of risk. You're really looking. So the person comes up to the front desk in a hospital and they say, this hurts. and you can ask them a couple of questions, and you can start to do pretty good prognostication of what the ailment might be, what resources are necessary to be consumed, and you can do everything from supply chain management to resource utilization within your system. And AI can do that. And there are some systems that have hundreds of apps that have been running that way for quite a while. The risk in that place, either from a bias or aspect, very minimal. Very minimal. Okay. I think the place where we will continue to be concerned, and I've said it before, it takes a lot of focus, is on the clinical decision support. It also ties back to the question that was asked earlier on the health equity component, because now you're starting to do predictive modeling and recommendations to physicians on outcomes based upon these anomalies. And so I don't know enough yet about how these, quote, reduced regulatory pieces are and what they read. You know, I'm getting the headlines, but I'm not seeing the detail yet. And if we follow the fundamentals, Steve Posniak was just named, as the interim lead on what we used to call ONC. So Steve's been there a very long time, really good person. He understands the ins and outs. Worked with Don Rucker and those since and past. So we're going to watch, listen, learn, stay very focused on our true north. You bet. Yes, sir.
Doreen from Diabetes Care Insights Radio. In many hospitals, health systems, provider organizations, there's a big push to reduce the cost of care. And many of these organizations are achieving that goal by incorporating digital health technology, AI, changing the care model to care models that are much more efficient. But there's also a lot of pressures to reduce to change the reimbursement model to more of a value-driven reimbursement.
Absolutely.
Can you comment on HIMSS's role on influencing possibly the new or the evolving value-driven models that either are occurring now or maybe coming down the pike?
Yeah, I mean, we've always been a fan of value-based care. And I think that what value-based care's end state and goal is an efficient healthcare ecosystem that tries very hard to treat individual patients with the best outcomes for these. And that's really what sits behind. Now that's an old expression. Sure. It actually came out of Intermountain. Intermountain, you know this, right? Okay, so you know the history. And so I always, when I heard that mantra from Intermountain 20X years ago, I personally adopted it, and I thought it was a fantastic thing. And I think that's what really is behind value-based care. We've seen pieces of it, and that's what Medicare Advantage is. Sure. Right? So that's an expression. Globally, we're hearing the same thing. So it's not just a U.S. thing. It's a cultural issue. You're going to see how it goes. But I don't think what we're trying to do is recognize and say, this is the best way to squeeze the highest level of efficiency, access, and quality through the use of these digital areas. There are other things that will contribute to that that's not in our space. We can get some digital health transformation. That's where we sit. That's great. I'm glad you know the Intermountain story. It was very cool. Yes, sir.
Thank you. It's Jonathan Fight, here on behalf of the Journal of Emergency Services.
Yes.
So I'd actually like to pick up the fire question, but not spell it with a
Okay.
So there are more people at HIMSS and the ecosystem certainly learning how to spell EMS, as we would like to say. Spell EMS.
Yes.
Emergency Medical Services.
Yeah.
But I'd like to ask you an education and awareness question, because about a month ago, give or take, the chief of Los Angeles County Fire was woven as in the aftermath of the fires there.
Yeah.
Who should be additional homeless in the situation.
Yeah.
The irony is, Los Angeles County has about 5 of those.
Yeah.
Several of which are represented at this conference, right?
Yeah.
This is true. And so, there's a disconnect somewhere, and I think to some degree, there's the question of are folks who are in the weeds on things like fire and so on. They're doing the work, but clearly that's a resource that people are looking for.
Yeah.
Not recognizing it's already there.
Yes.
There's a lot of noise in this ecosystem. What would you suggest, aside from, unfortunately, leveraging politics, like going to elected officials and saying, hey, why doesn't your chief know about the thing, which puts everybody in a defensive posture? What do you think? Quite seriously, like people would say, well, I don't know about it.
Yeah.
It's there, are you calling people? how do you recommend to marry up those existing infrastructure investments that are substantial and the agencies that are large and active and not anywhere? But they're not talking to each other. And what's the mechanism? And is it for example, I know there was a HIMSS conference in Southern California, AI conference, we're going to get out that one. But other than doing events like that, what can we as a community do to put these parties together where one is asking for solutions that the other is delivering? And they don't know.
Yeah, so,
Sorry for the extra long.
no, it's a good one. Look, I wish it was, I think it's the right way, an isolated incident, but it's not. We made changes in the US around homeland security in order to merge different databases to take a look at a sort of holistic view theoretically around, for the changes, to be able to monitor what's. We got caught terribly globally on our data when the pandemic hit. Because we had databases around the world that were not talking to each other, and they were not talking to each other. So what do? We get together with government relations, we say this is a priority, this is something we need to put on the radar. We go to Capitol Hill, we talk to the leads of different committees, it is a political issue, we get it for funding, because it's going to take funding to pull these things together.
If I may, I'm almost looking at a free perspective.
Sure.
There is no money. Is there an opportunity as an interest?
There's always money.
Well, I know it's an interesting.
But I mean, but there really is. To take any databases and put them
I'm
together.
talking about pure awareness. Because for example, we have other services like firefighters and medics who are already being paid with tax dollars. There are other colors of tax dollars that are being paid to support.
Sure, and it's an education issue.
What's the right forum in your opinion to get these folks together? How do we get them here? Basically, there's one.
Yeah, that's, so I'm gonna go back and give you the same answer I did. So what we do all the time is, if you look around, there's a number of states that are here that are representative states. And Missouri's a great example. It's talking about what changes they made in order to pull together a better data ecosystem for their state and how they were looking at managing against questions. And there are other states that are here as well. Okay? Well, they weren't here a few years ago. They're here now. Why? Because from a government relations standpoint, we put a lot on our government relations team. They're amazing, led by Tom Wood. And we reach out and we start talking about these issues at the state level and through our chapters. Because our chapters all have advocacy groups. I am a member of the Colorado chapter. I'm from Denver. And I think it's March 17th, but that's Advocacy Day. So is that a Monday? Someone check that for me? Okay, Monday the 17th. I'm going to be at our state capitol along with the other members of our Colorado chapter, going and talking to the state about what are their plans and what we're doing. And then we take common things and push it about. So let's talk about it after this and see how we can load the pipeline just a little bit. With the beautiful headline.
I'm Dr. Christina Madison from the Public Health Pharmacist. I have a selfish question. I've been to this conference twice, and I feel like I'm not seeing enough of my pharmacy colleagues here. So I was wondering, I know we have a nurse informatics specific. Have you thought about doing a little bit more robust outreach to the pharmacy community as they engage in the digital health space? I also honestly work in public health, and public health is here. But
we would love it. And the reason is that we would love it, first of all. Thank you for volunteering to help make that happen.
Okay, so
and
when
we will connect after this and we'll make it occur.
Okay.
It's critically important because clinical pharmacy is a critical part of EHRs. All of our modeling in safety at the individual and system level. It's an individual level, it's a liability level. Most importantly, it also enhances the formulas that are sitting inside every healthcare system that need to be utilized. So thank you for volunteering, and we'll tap into you right after this.
Thank you.
No good deed shall go unpunished. We have time. This is our last, our last question.
Susan Moore, South Carolina. News. You said a few minutes ago in answer to a question.
I don't remember that. No one remembers.
Direct resources to be funding workforce development and care in the home. And right now, the flexibilities for remote patient monitoring in the home expire March 31st. Is HIMSS involved at all in trying to get that extended?
Absolutely.
Okay.
So, look, we were involved in getting it in the first place, and we're going to be involved in pushing really hard to get it reinstated. It's critical. It's necessary. We don't have a chance as a society without extending home monitoring and back home. And by the way, individual monitoring, we say in the home, there's certain flavors of that, right? There's nothing more engaged than a patient that has information below. So we are huge fans of yes, we should. And we can set up, Susan, it's an opportunity to talk to Tom later if you can come in and give you the specifics of where we are. We have to do that. Well, listen, everyone, I just want to thank you so much for attending HIMSS 25. I think, you'll go out and interview and get a sense of the vibe, but it's just absolutely phenomenal what's going on. And it's rocking. I was lucky enough to kick off the class awards last night, and we had about 300-ish, maybe more, of the market suppliers in the room getting their awards, and they're tied to HIMSS. This is the second year in a row that we've brought, class and HIMSS have gotten together through our MOU and doing that. I'm really proud of our work around the world. We'll be signing an MOU, I think, later today with Turkey, and we reestablish that relationship. And we've been there before. This is the second time I've done it. And so this will be heading into years 11, 12, 13, 14, and 15 of our relationship in helping the Turkish Republic and Republic of Turkey in conjunction with the healthcare system. We're doing this around the globe. We're very proud of our growth. 5-6 years ago, we were sitting at about 80,000 members. Today, we're over 120,000. We've had the largest increase in membership gain at any HIMSS event in the last 4 years coming into this one. So we're very pleased, and we're happy with the numbers, and we hope that all the educational sessions and the panels and the information we bring forward will look healthcare forward. And thank you all so much for coming, and if you have different questions later on, I know between Albie and Christine we'll be able to answer them to the best of our ability. We'll get numbers and stuff out later. Thank you again for the volunteers. Thank you also, please, for the disability component. Let's not let that sit as well. We'll follow up with it. Thank you for coming.